All right, good morning, everyone. I'd like to thank Sarah and Dalen and the rest of the team for inviting me to a picturesque Vail. A little chilly, chillier than usual, I'm told by the locals. So today what I've been asked to do is to give updates on AML and ALL. So two different topics in the span of 30 minutes. I hope you've had your coffee, because this is going to be another lightning round like Dr. O'Donnell. But seriously, what I've tried to do is I went through the abstracts and try to pick out the ones which I think represent where the field is going. So not reviews on therapies that we already have and updates and things like that, but more of where in the next 3 to 5 years, what may be practice change, what will we be doing in 3 to 5 years compared to what we have been doing, how we've changed things. And what I've also tried to do is come up with themes, so themes of what, sort of big themes and kind of go through the evidence behind it. And so in AML, the themes are going to be, the use of allogeneic stem cell transplant. We know that the big advances in AML recently have been the development of targeted therapies, which have sort of revolutionized the treatment of subsets of AML, including Venetic Clocks. And so we'll talk about how Venetic Clocks, which is widely applied to older and unfit patients, how we can now broaden that application to younger and fit patients in combination with chemotherapy, how we need to look at who we select for Venetic Clocks-based therapy, how we combine Venetic Clocks with other lower intensity therapies, potentially in certain subsets. So that's sort of been the Venetic Clocks theme of the AML section. We'll also talk about transplant. Again, Ven is really highly sort of dominant in the AML field currently. In ALL, the word of the day or the big theme is antibodies, right? So for years we've been using multi-agent chemotherapy, steroids, maybe some antibodies, rituximab, but really the revolution has been the development of new antibodies, bispecific antibodies, primarily blinatumomab, which is a CD3, CD19 bispecific, as well as inotuzumab, which is an antibody drug conjugate against CD22, and how to not only use those as a single agent, which is what the label is, but how to incorporate that into our current chemotherapy strategies, A, and then B, how to completely get rid of chemotherapy and use just targeted therapy with monoclonal antibodies, and can we advance the field and move away from chemotherapy-based treatments in acute lymphoblastic leukemia. And so as I go through these slides, I want you to kind of keep these themes in mind. I'll try to distill out the primary points from each of these abstracts. Again, they're very complex or complicated. I've just picked a few slides, but I want to make sure that I present all these things to you. So the first is called the ASAP trial. The ASAP trial was actually a plenary session. This was one of the plenaries. And what they went about doing is they asked that simple question in a patient who has AML, who either doesn't respond to initial induction chemotherapy or who responds and then relapses, right? And we want to take them to allogeneic stem cell transplant because that's the only potentially curative strategy. Do you give them first chemotherapy, try to get them into a second CR, and then get to transplant, or do you just go to transplant right away? A question that we ask frequently in our clinics, and you'll be surprised by the answer. So the trial randomized patients, age 18 to 75 years, who had poor response after initial therapy or who had relapse after initial therapy to either what they called remission induction standard therapy, RIST, or watchful waiting, okay? So just disease control until the transplant was ready. We all know that we can't get transplants sort of mobilized within 2 to 4 weeks of chemotherapy. We need some time to do that. And so they randomized these two patients. Now it's very interesting and important to recognize what type of patients. So patients who had poor response, how do they define poor response to initial chemotherapy? Well, interestingly, they would define poor response as not responding to one cycle of 7+3 chemotherapy. So 5% or greater blasts after one cycle of 7 and 3. So many of us who have treated AML, excuse me, and given 7 and 3 chemotherapy, we know that we usually give 2 cycles to really call them primary refractory. In fact, there were several papers, including a large paper, suggesting that, in fact, 2 cycles of 7 and 3 is considered actually primary refractory. So keep that in mind. These patients, although having a poor response, that was only after 1 cycle of chemotherapy, so they may still be patients who are sensitive to further chemotherapy. And then what they received in salvage chemotherapy was a high-dose cytarabine-based regimen. But in the other arm, this watchful waiting arm, you could still receive a dose of mitoxantrone, some low-dose cytarabine to control the disease until stem cell transplant happened. So with those caveats, let's look into the data. So these are the patient characteristics, very well balanced. You can see that the majority in both arms were considered this poor induction or a poor induction response. So the minority, in fact, just a third of the patients in both categories were relapsed patients. These are patients who responded, relapsed. So you know that they have sort of really aggressive disease that may be poorly responsive to therapy, but the majority of these were poor response. And this is sort of the fish mouth plots to kind of show what happened to these patients. So first, what I'd like to point out here is that on the left, in the disease control arm, 3/4 of patients, 75% of patients, were bridged by just watchful waiting. So they didn't receive the low-dose cytarabine and the mitoxantrone, they were just watched. So that's interesting. Primary refractory AML, you're watching them for about 4 weeks, maybe 6 weeks prior to therapy. Do they really have aggressive disease? Is their disease actually under control? Who knows? Just something to keep in mind. The second thing is you see the median time to transplant. 4 weeks on the left, 8 weeks on the right. So clearly you can get to transplant quicker if you just do watchful waiting and potentially move to transplant. The second thing I'd like to look at is on the right side in the remission induction arm, the CR rate after that second induction, right? So then the remission induction arm proposed that we would give you chemotherapy in the salvage setting with high-dose cytarabine-based therapy and then go into remission and then move on to stem cell transplant. You can see that half the patients, 50% of those patients who were refractory to initial therapy ended up having complete remission. That's actually a pretty good response rate, a little bit higher than I would expect, suggesting that you're still dealing with people who had sensitive disease. And if you remember, these are randomized patients, so you have similar patients to the other arm. So the overall gist of this is potentially these patients were potentially not as refractory as you would think. And the outcome in the bottom line here, you can see here, there was no difference whether you gave remission induction chemotherapy prior to stem cell transplant or took them directly to transplant, which either watchful waiting or a little bit of low-dose cytarabine. No difference in leukemia-free survival, no difference in overall survival, with the caveats that I mentioned below. The first thing that strikes me is, okay, great, there's no difference. Maybe now we can start pushing our transplanters to kind of take these people sooner instead of requiring MRD negative, clean, complete remissions, Olympic athletes taking the transplant. Now we can say, hey, guys, take them to transplant. We have a randomized trial. But the other thing that jumps out at me is look at that overall survival in patients with relapsed and refractory and primary refractory AML. Long-term survival is 60%. That's pretty good, even with stem cell transplant. So I think these potentially are patients who may still have disease that's sensitive, but nonetheless, a very compelling argument to move quickly with allogeneic stem cell transplant up front. Who are the patients that benefited the most? You can see I highlighted a couple things here. Most people sort of fell right down the middle, whether you received remission induction therapy or watchful waiting. But the people who tended to sort of benefit the most from just moving straight to transplant, those with adverse karyotype, those with secondary AML, those who have high HCTCI scores, so those with adverse performance status. So that tells me that those patients who have, the way I interpret this, is those patients who have that refractory disease, complex karyotype, secondary AML, that's not going to really respond to another cycle of chemotherapy. Let's not wait, let's just move them quickly to stem cell transplant without this fooling around with different therapies. And certainly those are the people that tended to respond the best in this forest plot. All right, so let's get into a theme of Venetic Clocks-based therapies. So we all know that HMA-Ven has been a sort of a revolution for patients who are older than 70 or unfit for intensive chemotherapy, really improving the response rates around 65 to 68%, median survival 14 months. Now that we have the ability to use Venetic Clocks, we immediately start thinking, how do we use this now to improve the outcomes in younger patients, fit patients with newly diagnosed AML? What if we could get to response rates not of 60, 70%, which we currently get with standard chemotherapy, 7 and 3, et cetera, but what if we can get response rates in the range of 90 to 100% to make sure that our patients, they go into remission? Remember, the number one factor that predicts for overall survival in patients is the ability to achieve a complete remission with your first induction. So what if we can try to reassure or assure that these patients get into remission? That's the hypothesis that we went on when we tried to embark on these studies of adding Venetic Clocks to intensive backbones of chemotherapy to try to improve those response rates, improve the rates of MRD negativity, and get them to transplant in a very nice MRD negative state. The first study here, CLIA plus Venetic Clocks. These are the drugs that we use. I'd like you to pay attention a little bit to the doses because they change as we go through the 3 therapies. There are 3 intensive chemotherapies that I'm going to discuss today: the CLIA plus Venetic Clocks, the FLAG plus IDA plus Venetic Clocks, and the 5 and 2 Venetic Clocks. And there's also the FLAG IDA Venetic Clocks. So the bottom line or the summary of all these is we use intensive chemotherapy at varying doses of cytarabine with anthracyclines with Venetic Clocks. But instead of giving Venetic Clocks at the traditional 28 days, which is the label for HMA-Ven low intensity, we realized that the myelosuppression, the toxicity, would be significantly enhanced. And so we actually reduced it. You can see here only 7 days of Venetic Clocks with an intensive backbone that includes 1.5 grams of cytarabine, okay? This is the baseline characteristics, median age of 48, so young patients, all under the age of 65. You can see that 40% of these patients had adverse ELN risk. So not just, yes, go ahead.
That dose 400 is regardless whether they're on antifungal?
No, this 400 is the target dose. So if they're on posaconazole, 70 milligrams. If they're on voriconazole, 100 milligrams. If they're on diflucan, 200 milligrams. So azole-adjusted dosing. Okay, good question. So what do we get? Composite CR rate, CR rate 96%, including an 85% CR rate. That's complete count recovery, 100,000 platelets, 1,000 ANC. So yes, there is myelosuppression, but these people, when they go into remission, they achieve a complete remission rate of 85%. Importantly, 90% of the people who achieve remission were MRD negative at the time of remission. So really, really deep responses with intensive chemotherapy and venetoclax, what we were hoping for. Did we see mortality? Sure. Only 1.5% mortality at 4 weeks, 3% mortality at 8 weeks. So well tolerated, we use supportive care, et cetera. This is the overall survival. 2-year survival, 71%. Again, not reached. This is an excellent outcome in terms of newly diagnosed AML, even in younger fit patients. And when we divide it by ELN risk, look at those people with ELN favorable, they essentially have a flat line with 80 to 90% long-term survival. But even those with intermediate and adverse ELN, the people that we worry about the most, had a very good survival with a 2-year survival of 60% or higher with this disease, with this therapy. Adverse events, as you would expect, with intensive chemotherapy and venetoclax, you're going to see lots of infection, lots of myelosuppression. That's what we did see. What we remember to do is we use GCSF when they're in remission. We use antibiotic prophylaxis, antifungal prophylaxis in everyone. We follow them closely, and then we adjust the dose on subsequent cycles. And you can see here, this is the time to count recovery after cycle 1 and cycle 2. Everyone recovers that counts by day 27 on cycle 1. With cycle 2, there is a slow platelet recovery, and we actually associated that with the use of posaconazole, which actually bumps up the venetoclax levels even higher than what we initially thought. A similar study, instead of using cladribine, they use fludarabine. This is from Italy. Their dosing strategy a little bit different. That's what I'm going to focus on here. So they did a ramp-up dosing. We did not use a ramp-up dosing because we started on day 2. We gave the chemotherapy on day 1, which cytoreduced them. But they used a ramp-up dosing, and instead of giving 7 days, they gave 21 days of venetoclax, okay? A little bit scary, but certainly they did that. And again, what did they see? A composite complete remission rate, 88%, MRD negative, 74%. Really, really high rates of MRD negative response rates in a frontline population of intermediate and adverse risk AML in the hands of academics in Italy, but a multi-center effort to produce this. So this can be replicated in other places. This is their overall survival. Again, a little bit lower, long-term survival, 2 years, about 55 to 60%, but still very, very favorable in this difficult population. And once again, they saw what we saw, sepsis, myelosuppression as the primary issue, but very few deaths from the sepsis and myelosuppression, right? So if you manage it adequately, you jump on these cases, you put it in the hospital, IV antibiotics, GCSF, 30-day mortality 2%, 60-day mortality 6%. So very, very acceptable in this difficult population. And finally, a lower intensity approach, but not quite lower, but still using anthracycline and cytarabine here with 5+2. This is from Chin Chua from Andrew Way's group in Australia. And here she summarized all the different trials for us. But what they used is 5+2 plus venetoclax. You can see the CR rate, 72%, with a median overall survival, 11.2 months. But look at the age difference. These are patients who are 60 and older. So median age of 72. Right? These people are sort of older, like, you worry about whether you want to give them intensive chemotherapy, but they gave them intensive chemotherapy plus venetoclax in a very difficult population. And they used a different venetoclax dosing strategy where they started to ramp up before the chemotherapy, 7 days before, and they gave venetoclax 7 days after. So a total of 14 days of venetoclax, 7 in combination with chemotherapy. And you can see here their overall response rate, 73%. But if you looked at those patients who did not have secondary AML, but de novo AML, 90% overall response rate, with a median survival of 31 months in a patient population with a median age of 72 years, right? So this is extremely interesting data. I think as we go forward, as we work our practice, we're going to optimize how we use intensive chemotherapy, select the right patients where we combine it with venetoclax, and hopefully achieve responses that confirm this. And again, confirmatory studies are underway. Okay, moving away from intensive chemotherapy and venetoclax, we have and we use daily low-intensity therapy with venetoclax. So how do we optimize this therapy? This was a very interesting abstract by Harmit Donor and colleagues, and what they did is they went back to the VLA population. These are patients who are older, unfit, with newly diagnosed AML, and they looked at the outcomes of HMA-VEN by ELN risk. We used to have ELN 2017, which is a risk stratification We now have EL in 2022, right? Minor differences, but significant. And they went through each of them and said, well, how does HMA-VEN perform compared to HMA alone? And you can see within each of the subgroups, favorable, intermediate, adverse, HMA-VEN was better. Great, that's what we think. But then they went back and looked, what do we actually really do in our practice? And when you're treating a lot of AML, you see this over and over, you see these patterns. You see, man, we have these P53 mutated complex karyotype people. We give them HMA-VEN, they don't respond, they live 6 months and die. We have these people with FLT3 mutated, RAS mutated AML, we give them HMA-VEN, great response rates, they relapse very quickly, they move on to salvage therapy, they die. People with NPM1 mutated, diploid karyotype AML, HMA-VEN, beautiful response, beautiful survival, never relapse. So what he did is he went back and applied this very simple molecular signature to the AML patients. He said, let's just take 3 mutations, P53, RAS, and FLT3. If you're P53 mutated, you're on that blue curve, period. Not very well. You didn't do very well. If you're P53 wild type, but if you're mutated in either or RAS and FLT3, you're in that middle curve. And if you had none of these mutations, you're in the top curve. So using these very simple 3 mutation signature, he applied this and he saw very quickly it divides beautifully, right? And then when he went back and looked, he said, who was the higher benefit group? Those people who were in the no mutation group. You can see that on the left, HMA-VEN clearly showed a significant survival benefit. If you look in the middle, those people who had either their FLT3 or RAS mutation, well, no, you're not seeing that survival benefit anymore. It's still better, right? But not significantly better than HMA alone. And certainly in the lower benefit group, those who have P53 mutations, there's absolutely no benefit for adding venetoclax in these patient population. And this is what we're seeing. And this is, I think, as we go forward, we have to start looking at those second 2 groups. Can we add something? Can we change something either in the backbone or in addition? You'll see this in one of the later abstracts, to improve response in that intermediate group, potentially those FLT3 mutated patients. And what about P53, which has been the big bugaboo, and that is an intense area of research currently. So the next study looks at further optimizing the dose of venetoclax. Many of you who have treated AML in the community or even in academic practice, you start with HMA-VEN, maybe you give 28 days during cycle 1, maybe during cycle 2. As you move on, cycle 3, cycle 4, cycle 5, what happens? You can't give 28 days of venetoclax. You go down to 3 weeks, you go down to 2 weeks, you go down to 7 days. There are some days I give 3 days of AZA and 3 days of venetoclax just to kind of maintain them long term because there is myelosuppression. People can't start their next cycle. So the French group did a very, very interesting study, retrospective. They went back and looked at, in their multi-center analysis of patients in France who received only 7 days of venetoclax and 7 days of AZA, so 7 and 7. They never got 28 days of VEN. This was the induction. This was a very difficult group of population, but 7 and 7 was what they give. 33% at poor risk cytogenetics, 20% at a P53 mutation. This is much more adverse than what the VLAA cohort had. And so you can see here, these are very frail patients as well with adverse performance status and adverse risk. So poor population, they said, let's give 7 days and 7 days. How did they do? Overall CR/CRi rate, 68%. Okay, interesting. In the normal karyotype, 81% response rate. Complex karyotype, 47% response rate. This looks awfully familiar to the VLAA, which gave 28 days of venetoclax. These guys only gave 7 in a much more difficult population. You can see here, early the 60-day mortality, 6%, very similar to what you saw in VLA and other HMA-VEN-based studies. And the toxicity tended to be a little bit lower than what you saw with 28-day venetoclax in a frail population. And the survival, 12.8 months, similar to the 14-month median overall survival that we saw and that was recently updated at ASH as well. And so this is quite compelling. Do we really need to give 28 days of venetoclax to everyone during cycle 1? Can we give 7 days? Can we get the cycles closer together? I think certainly this is an important argument. Certainly at MD Anderson, we've been doing this since the beginning. We give 21 days, 14 days, 7 days, very quickly use of venetoclax. And that allows us to keep patients on venetoclax longer. So it's not that we're pulling therapy back, but it keeps them longer in remission on therapy in a consolidation approach. And finally, how else do we optimize therapy for venetoclax-based strategies? I showed you that intermediate group, those patients who had FLT3 mutations where there was very little benefit from the addition of venetoclax to azacitidine. This is a triplet combination that was pioneered at MD Anderson, looking at a combination of AZA-VEN with the addition of the FLT3 inhibitor gilteritinib. Okay, so these are patients, there are 2 cohorts, one with relapse refractory where we started to make sure that the combination was safe. And in fact, what we found is that we could only give 14 days of venetoclax with the combination triplet, and we could only give 14 days of gilteritinib with the first cycle. On subsequent cycles, we allowed the gilteritinib to advance to 28 days, but only 14 days during the first cycle, and then venetoclax was dropped to 7 days. You can see here very clearly, this is based on work that we did with the relapsed refractory population. We then use this now in the frontline population. And bottom line here in the frontline, you can see the CRC rate, 27 out of 27, 100% complete remission, composite complete remission rate, with 92% of those patients achieving a complete remission with count recovery. Now, what helps with count recovery? Stopping the venetoclax at day 14, stopping the gilteritinib at day 14. This allows marrow recovery because hematopoietic stem cells can also be sensitive to the combination of gilteritinib and venetoclax. And you can see here early follow-up, right? So nothing too much to take away here, but certainly promising median survival not reached with a 12-month survival around 70% in this difficult population of FLT3 mutated older patients. So can we now add a drug to then improve the response rates? You can see here also high rates of MRD negativity. Okay, 2 Menin inhibitors. So what are Menin inhibitors, right? So we don't, let's just get into that real quick. So Menin inhibitors, go back. I guess it skipped the slides. So, okay, Menin inhibitors are drugs that target a protein called menin, which is involved in transcription, okay? So if you remember, there are a subset of AML and ALL for that matter called MLL rearranged, right? MLL rearranged, 9/11, 14/11, 11/14 translocation. These are high-risk AMLs and ALLs that have a high risk of relapse. These are patients we often send to allogeneic stem cell transplant first remission, but they relapse nonetheless. They are now called KMT2A. That's the gene that is responsible as histomethyltransferase. And so the histomethyltransferase KMT2A actually associates with menin at the transcriptional level. And if we are able to target that, can we disrupt the abnormal menin? So there are 2 menin inhibitors currently being presented. One is called Syndax or revumenib in a phase 1 study. And I'll go very quickly. This is the bottom line, is that these things are safe. They have single agent activity, which is very promising in a highly refractory population of patients where nothing used to work in the past. So this is the menin story. The adverse events that we see, usually QT prolongation. There are a few patients at the higher dose level. We saw something called differentiation syndrome. So if you remember, menin or MLL translocation causes differentiation block. This actually removes that differentiation block. And so now suddenly you have 10 to 100 million or 500 million blasts suddenly you want to become monocytes and neutrophils and basophils all at once. And that cytokine release causes significant symptoms, which actually can be life-threatening. It actually led to a couple of patients with mortality early in the study. So very, very difficult, but with dose reduction, slow escalation, we're able to see less and less differentiation syndrome. Bottom line, the CR/CRh, 30% with a single agent targeted drug, no chemotherapy given. Similar, this is the Cura compound, ziftomenib. And what we saw here similarly in these patients, anemia, thrombocytopenia, myelosuppression as you would expect, but essentially the bottom line, 30% response rate. So the takeaway from these studies, as a single agent in a heavily pretreated population of MLL rearranged or NPM1 mutated AML, response rate around 30%. Now there are ongoing studies with combination with chemotherapy in this patient population. All right, so now moving into the second talk. It's going to be abstracts in acute lymphoblastic leukemia. So here I'm going to do more of a rapid fire lightning round. And I think the bottom line, just so you guys are all focused on what I'm trying to say, is that monoclonal antibodies such as blinatumomab and inotuzumab are now starting to completely change the paradigm of what we used to do in acute lymphoblastic leukemia. We're adding them to chemotherapy. You've seen the mini hyper-CVAD data. I'm not going to present any of that. But what if we add that in consolidation? Can we prolong survival? What if we use that to eradicate minimal residual disease? What if we combine it just with a target inhibitor, give no chemotherapy? Can we improve outcomes? And that's what we'll see here. So the first is the E1910 trial, a randomized trial which asks the question, people receive induction chemotherapy, they achieve a complete remission, they receive 1 cycle of intensification therapy, consolidation. Then they're randomized to the blinatumomab arm or the no blinatumomab arm. In the blinatumomab arm, you get consolidation chemotherapy with blinatumomab sort of inserted in there. The other arm, you just get consolidation chemotherapy. Then you move on to further consolidation chemotherapy. On the blina arm, you continue to get a little bit of blina. On the other arm, you just continue to get consolidation therapy. Both move on to maintenance therapy and do what you normally do. Right? So all we're doing here is in one arm, we're adding a little blina in the consolidation and the post-induction setting. And what they found, you can see the curve from back of the room, a significant improvement in long-term survival with patients who received blinatumomab intercalated as a consolidation strategy in people who were already in remission. Right? So blinatumomab is supposed to target CD19 in positive cells, and it was initially developed in patients who had detectable MRD. These people may or may not have detectable MRD. In fact, 224 people who are MRD negative were randomized, right? So even though they were MRD negative, right, there's still disease there you can't see. The blinatumomab was able to significantly improve outcomes, suggesting that there is a role to introduce these antibodies earlier into the treatment. A secondary study, similar, looking at high-risk patients with blinatumomab consolidation. These are people who received induction, one consolidation therapy. They had persistent MRD at a level of 0.01% after one consolidation or 0.1% after the initial consolidation, and they received blinatumomab as induction. You can see in the table there, a significantly higher proportion of patients became MRD negative with the addition of blina, and there was an improved disease-free survival rate that was significant. The OS did not achieve significance, probably because those people who had a relapse were then salvaged with blinatumomab or inotuzumab and had no survival benefit, but certainly a DFS benefit, again, strengthening the cause of using these antibodies earlier in therapy. What about subcutaneous blinatumomab? I think Dr. O'Donnell brought up earlier the use of daratumumab subcutaneously. You know, for anyone who's given blinatumomab, it's kind of a burden, right? You have to wear this fanny pack. It's a continuous infusion for 28 days. You start the drug, they have to switch the bag every week. They have to come back in. They take a shower with their bag. They sleep with their bag. You can't disconnect it. What if we had a subcutaneous version? And indeed, they've developed a subcutaneous formulation, and so far the response rate looks very good. And this, if matches the continuous infusion blinatumomab, may become a part of the standard of care. We know that blinatumomab has been used to eradicate MRD in acute lymphoblastic leukemia. What about using inotuzumab? There are two studies here showing that indeed inotuzumab has activity in eradicating minimal residual disease in patients with persistent MRD, even among patients who are Philadelphia positive, as you can see here, as well as those who have previously received blinatumomab. You can see here about 35% became MRD negative, 5 out of 12 to Philadelphia negative, and 25% in patients who were Philadelphia positive. The second study done at our institution, same thing, took patients who had MRD positive disease in CR1 or CR2 and gave them inotuzumab to eradicate MRD. You can see here now that 67% of those patients who received therapies, or 2 out of 3 patients, achieved MRD negativity after getting inotuzumab in that MRD positive setting. A really nice approach to get people MRD negative, potentially as a bridge to allogeneic stem cell transplant or long-term survival and maintenance. This is a nice study from Canada looking at the question of whether or not we should do stem cell transplant in Philadelphia positive acute lymphoblastic leukemia. We know that we've had dramatic improvement in outcomes in Philadelphia positive ALL with the introduction of TKIs in combination with chemotherapy. We have hyper-CVAD dasatinib, now recently hyper-CVAD ponatinib, high rates of complete molecular remission. Yet, the textbooks or the board courses will still say, well, you need to take these people to stem cell transplant. They're high risk, right? So these folks did a study looking at, do you really need to take these patients to transplant? Because more and more, at least in the academic community, we sort of just kind of maintain them with single agent TKI indefinitely, and they stay in remission and sometimes live a normal life. And you can see here that actually there was no difference whether or not you went to stem cell transplant in Philadelphia positive ALL. And if you're curious, the not transplanted group is actually that blue curve, and the red curve is those patients who received allogeneic stem cell transplant, presumably having issues with post-transplant complications, GVHD, et cetera. So no difference. Again, a small study certainly needs to be expanded and confirmed. And finally, the last study I'll touch upon is a chemotherapy-free regimen, right? Acute lymphoblastic leukemia, which actually started with multi-agent chemotherapy in pediatric ALL, using every single chemo, throwing it all together, achieving high rates of cure. Now with chemoimmunotherapy, adding antibodies, what if we just drop the chemo altogether, since we have 2 great drugs, ponatinib, a highly active TKI in Philadelphia positive ALL, as well as blinatumomab, that CD3, CD19 BiTE. This is the schema in terms of how we treat patients. So induction consolidation, start with 30 milligrams of ponatinib, drop to 15 if they're in complete molecular remission. And what we see here is the characteristics, but 96% of patients had complete remission or CRI, with 97% having major molecular response and 87% having complete molecular remission with this approach. And so far, knocking on wood, these patients have had an excellent long-term outcome. One of the primary concerns that we have, and we had, and we continue to have, is that with dropping the chemotherapy, we dropped this courses with high-dose methotrexate, high-dose Ara-C, which were very effective at controlling CNS disease in patients with Philadelphia-positive ALL, where we see a lot of CNS disease. And so one of the concerns we have is that if we just drop all the chemotherapy, we don't really know how much blinatumomab affects CNS disease, and ponatinib may or may not cross the blood-brain barrier. So we have intensified the number of intrathecals. We do 12 intrathecals and sometimes more in patients who are on this trial. And then we're starting to really carefully look to make sure that there's no evidence of CNS relapse in this sort of this short to medium follow-up that we have, because that would certainly change the paradigm to go back to a little bit of intensive CNS penetrating chemotherapy to prevent CNS relapse as a major issue going forward. So I will stop there. I'm happy to take questions during the panel. Thank you very much.